Bruce Harold's my name. I'm a professor at the Department of General Practice at the University of Auckland, and this talk is about common infections in primary care. This is different from what you would see if you were working in a hospital. So in terms of antibiotic stewardship, 50% of Kiwis get an antibiotic each year compared to about 5% of people in the Netherlands. So you can make your own conclusion about that. This contributes to rising resistance. There are some solutions to this. One is to give delayed antibiotics, which can reduce antibiotic use by 50 to 75% of use. But the problem with that is that you're saying to patients it's okay to have an antibiotic. And I think we should really be saying, no, come back and get reassessed if you're not better. There are obviously financial and time issues for patients over that. We probably need another public campaign. The Pharmac campaign in the early 2000s was hugely successful in dropping the number of antibiotic use. The other complication we could see more of is C. difficile. So that's pseudomembranous colitis. In the UK, this is a lethal condition. It doesn't seem to be lethal here. It's due to a toxin produced by C. difficile, and C. difficile seems to you get an overgrowth if you give regular antibiotics, and it's the toxin that causes the problem. And if you want to test for the toxin, you can't just ask for a stool culture. You have to ask for C. diff toxin. It's a special test. It has to be a fresh stool sample that's loose and put onto ice quickly. So they're looking for the toxin, not the bacterium. So that's an important take-home point when ordering stool cultures. There's the issue of what antibiotics do to gut bacteria, some serious damage to normal flora in the gut and nose and mouth. And then there's the issue of the role of probiotics. This is still a work in progress. It's essentially various forms of yogurt, but the studies use forms of probiotics that aren't easily or recognizable in New Zealand. In terms of antibiotic stewardship, the key underlying principle is in primary care, most antibiotics are discretionary rather than mandatory, and we'll talk about the conditions that are mandatory. There's also a move to shorter courses and for some things higher doses. For example, with cellulitis, we now give flucloxacillin rather than 500 milligrams 4 times a day on an empty stomach, 3 times a day at 1,000 milligrams with food for 5 days if the patient's getting better. So as we said before, antibiotics are discretionary other than for some things such as strep pharyngitis in Maori and Pacific patients, otitis media in children under the age of 6 months, pneumonia always. And just remember that many of the studies done in primary care eliminate people who are severely ill, and those people may benefit from antibiotics. And they don't get into trials of sinusitis or otitis media. And also remember that in primary care, most antibiotics are given for symptoms, respiratory symptoms, not bacterial diagnoses. So we need to reduce the antibiotics given for respiratory symptoms. So the first condition I want to talk about is acute bronchitis. This is a condition that almost certainly does not exist. Some people define it as a cough plus or minus sputum plus or minus lower sounds. Well, that could be a mixture of common cold, asthma, pneumonia, or COPD. And antibiotics work for pneumonia and exacerbations of COPD, but not for the other things. So the Cochrane review is actually confounded by patient mix. Often it's used as an excuse by doctors to give an antibiotic. I think this patient has a bronchitis, so it's an itis, so I can give an antibiotic. That's not good thinking. You can give non-steroidal anti-inflammatories or paracetamol for acute bronchitis. If the patient has lower respiratory tract signs and you don't think they have pneumonia, they probably have bronchospasm. They may benefit from an inhaler, a salbutamol inhaler, or a course of oral steroids. And then there's the issue of delayed versus no antibiotics. And as I said before, although I've done research on delayed antibiotics, I favor the use of a no antibiotics policy, people are less likely to come back for the same symptoms. The problem with giving antibiotics or even delayed prescriptions is you're medicalizing the patient and you're making them think they need antibiotics. Acute bronchitis, you need to remind people that cough takes 4 weeks to go away. So you have to point out that they're not going to get better quickly, so that they aren't coming back in a couple of days saying, I'm no better, can I have antibiotics? Sputum's of no value in this situation. The patient may have pertussis even if they're an adult, and you need to check if the patients want antibiotics, and I use the passive voice for this. Is there something you were hoping I could do for you today? And that should hopefully get the antibiotic issue out, and then you can deal with it. Sometimes patients just want a note for work, sometimes they want reassurance. A lot of doctors think patients want antibiotics, and there's quite a bit of research showing that patients actually don't necessarily want antibiotics, they want to find out what's going on. But we just assume they want antibiotics and we give it to them, so it's a reinforcing cycle. Common cold, antibiotics here of no use. The issue of secondary bacterial infection, if your sputum becomes coloured, is an urban myth, not based in any reality. And studies showing patients who have productive sputum makes no difference after a week. You can use nasal or oral decongestants. If they've got a particularly vigorous rhinitis, you can use ipratropium nasal spray. In terms of oral decongestants, you can use pseudoephedrine, 60 to 120 milligrams. Give it in the morning, otherwise you'll keep the patient awake all night. This is a very powerful decongestant. You can write it on, it's a controlled drug, and you can write it on an electronic prescription without having to go through the whole circus of prescribing a controlled drug. Nowadays, it's much easier. I never give more than 6 or 8 tablets because it is the precursor to methamphetamine. However, methamphetamine in New Zealand is usually coming in over the border in 100,000 tablets. The 8 tablets you give to your local accountant is not going to end up in the methamphetamine cycle. There is about $1.20 part charge for each tablet, so you have to warn patients about that. The other option is nasal decongestant, so xylometazoline. That's a very potent vasoconstrictor. It costs about $15. It's not funded at the moment, which is unfortunate. But, and there is a combination of half-dose xylometazoline and half-dose ipratropium. I've not seen any effectiveness studies on that. You can also use non-steroid anti-inflammatories or paracetamol. In children, you can use Vicks, and if they've got a cough, you can use honey in those over a year old. There's a risk of listeriosis in under 12 months. Acute sinus symptoms. So this is a very common problem as an adjunct or a complication of the common cold. People often feel some fullness and a bit of discomfort. If they truly have bacterial sinusitis, they should have facial pain, a nasal discharge, dental pain, and some nasal congestion. And theoretically, percussion of the maxillary or frontal sinuses should elicit tenderness. However, in most cases, these are acute viral sinus situations, and the patients are rarely very sick. The first choice here should be decongestants and analgesics. The NICE guidelines in the UK suggest increasing intranasal steroids and using a rinse with the patients if they're not getting better. Not much evidence about that. However, this is a cause of 80% of patients in the United States get antibiotics for this, and most are unnecessary and contributing to that overprescribing. There is the issue of so-called second sickening. So after about a week, the patient is starting to get better and then suddenly gets worse again. So the guidelines suggest that if the patient is very toxic, we would give antibiotics. If they have symptoms that last more than 10 days, and severe symptoms lasting for more than 3 consecutive days, or worsening symptoms after the last 3 consecutive days. I've gone back in the literature to find out where sickening came from, and I have yet to find any empirical evidence for second sickening. I think somebody thought it was a good explanation for bacterial sinusitis and made it up, as a lot of things in medicine are, and then handed down from generation to generation. So it's sort of become gospel in ear, nose, and throat terms, but actually it's not based on any empirical evidence. And it's extremely unusual to see somebody having a temperature for 10 days. And I would say you might want to talk to an ENT surgeon in that situation in case they have a collection. Just remember, some patients with acute sinusitis can get very, very sick. A very small fraction of % get collections in their sinuses, but those people will look pretty sore, pretty sick, pretty toxic, and they probably need to see an ENT surgeon. Otitis media, quite a controversial area. High-risk patients are those with systemic symptoms or age less than 6 months, so they would all get antibiotics. If they're less than 2 years, only give antibiotics with severe or bilateral infection, or with perforation, or with otorrhea and no improvement within 48 hours. You might want to consider them in children with recurrent infections, otherwise treat symptomatically with paracetamol. And back pockets prescriptions of otitis media do result in a 75% reduction in antibiotic use. The other thing is I would give antibiotics more readily to Maori Pacific children because they have a higher rate of mastoiditis. So I think you have to take local context into account. This is an example of an acute otitis media. No chance of missing that. Completely bulging, abnormal drum. So there's a whole collection of pus behind there. But the interesting thing is antibiotics don't speed up the resolution of it, they just reduce the pain. In terms of BPAC, they would suggest using amoxicillin, 15 milligrams per kilogram 3 times a day for 5 days. Treat for 7 to 10 days of age less than 2 years. If there's an underlying medical condition, bilateral otitis media, perforated drum. For severe or recurrent infections, you need to go to higher doses because there's possibly a bit of resistance to amoxicillin. So 30 milligrams per kilogram per dose. So that's 90 milligrams per kilogram today. So it's a pretty whopping dose. You need to write on the prescription, this is a high dose, so you don't scare the pharmacist. There was a trial in the New England Journal of Medicine where they gave Augmentin for 5 versus 10 days. They got a 10% extra reduction in symptoms. That's symptoms, not improvement in hearing. But the price they paid for the extra 5 days was 30% got diarrhea and nappy rash. So that's pretty ferocious. And Augmentin's not a good drug to use for first choice. And remember, the first choice indication for Augmentin is diabetic ulcers that are infected or animal or human bites. There are no other conditions that Augmentin is a first choice for. It's a very good drug, but it does have quite a bit of toxicity in terms of side effects. You can almost certainly guarantee diarrhea, and I've had 2 patients end up on ventilators with liver failure. Pus in the ear canal is a common problem. In a child, it's usually due to pus coming from the middle ear, so chronic suppurative otitis media. In an adult, it's usually otitis externa, often caused by cotton buds in the ears. The treatment for this is antibiotics and steroids. We don't know whether steroids alone will help, but we certainly know that acetic acid is not as good as antibiotics and steroids. So this is pus in an ear canal. You can hardly see the drum. Sometimes the pus is pouring out of the ear and you can't see anything. In terms of pus in the ear canal, generally you would not take a swab. I'd only swab people who have unusual situations. I had a man in his 50s and the pus was pouring out of his ear and he'd never had otitis media. Interestingly, he had a cochlear implant on that side and he turned out to have mastoiditis. So I was very glad that I had a swab which was able to guide the hospital in terms of antibiotic use. We don't give oral antibiotics in this situation, topical's enough. Suction's not needed in primary care. The only advantage of suction is you can see a perforation in the drum and therefore confirm that it's coming from the middle ear. But in the trials in primary care, just putting antibiotics and steroids works. If a drug was funded, we would use ciprofloxacin and hydrocortisone, but that's not available. Cochrane suggests steroids or antibiotics or both. That's still not clarified. BPAC suggests Volsol, which is acetic acid, 2% if it's mild. If it's more problematic, then Locortin, which is a steroid plus an antifungal with some antibiotic properties, Clyoquinol. The other one is Quinahocume, which is funded. It's got steroid and 2 antibiotics, but it's also got nystatin, which you don't need. Nystatin is mycostatin, which is an antifungal. Sofradix is probably the best one to use, but there's a part charge on it at the moment. That's got 2 antibiotics and a steroid. So that would be best practice, but you have to check with the patient if the part charge is an issue. So I say to patients, this has got a part charge of $3 or $4. Is that an issue for you? And the patient can then say yes or no. Pus in the ear canal, antibiotics alone include Framacetin, which is the part charge. You can use ciprofloxacin eye drops, which are funded, but you need to clearly explain to the patient that although it says they're eye drops, they're meant to go in the ear. I've had people put them in their eye, sort of following the instructions on the bottle. There's no evidence that topical steroids alone work. Now, there is a condition called necrotizing fasciitis, which is a surgical emergency, and this will occur in adults with diabetic pain, and they come in with extreme pain. So you wouldn't expect pus in the ear canal to usually be associated with pain. So this requires an ENT consult, but it'll only happen in diabetics, so this would usually be adults. Very rare. So the patient would have a reduced immune status or diabetes mellitus. There's a condition called cholesteatoma. So this is known as skin in the wrong place. So it's an overgrowth, a sort of benign overgrowth of skin in the middle ear, which can go on to cause quite a bit of damage. So you need to get onto these things quickly. This is a case of a congenital cholesteatoma, and I've actually seen one which I referred off, not because I thought it was a congenital cholesteatoma, it just looked very weird. It just wasn't something, it just looked, it's one of those things in primary care, you may not know what it is, but it doesn't look like it's normal. So you need some advice. This is a more typical cholesteatoma. That looks bad news. So that would suggest to you there's a hole in the eardrum and there's something not good going on down there. So that would require a fairly urgent referral to an ENT surgeon. The other complication of middle ear infections is mastoiditis. So you get, in this case, redness and swelling, and this would be painful. Not always that easy to pick up, but the person not getting better with oral antibiotics may require this. They require surgical drainage and intravenous antibiotics. So it's, again, as an immediate surgical referral, should you think of it. And as I say, more common in Maori and Pacific children. Another condition requiring antibiotics is COPD exacerbation. So 2 out of the 3 following symptoms would suggest an exacerbation: increasing dyspnea, increasing sputum volume, and a decrease in lung function. This is the classic hyperinflated chest of somebody with COPD. So they will have damaged alveoli, and so the lung expands to provide a bigger surface area for oxygen because of the damage to the alveoli. This person will have a barrel chest and perhaps be breathing with pursed lips to try and increase the pressure in the lungs. In terms of which antibiotics and when to use Augmentin and the role of steroids. So in terms of COPD exacerbations, you only need 5 days of antibiotics, 500 milligrams TDS for 5 days, or doxycycline, 200 milligrams stat, and then 100 for 5 days. With pneumonia, don't give ciprofloxacin. You can give 500 to a gram TDS 5 to 7 days. If somebody truly has pneumonia, they will be feeling a lot better within 24 to 48 hours. If they're not improving within 48 hours, consider Mycoplasma pneumoniae or Legionella. and then you'd give roxithromycin 300 milligrams once daily for 7 days, or doxycycline 200 milligrams BD on day 1, and then 100 milligrams BD day 2 to 7. You need to know if there's Legionella in your area, and that varies from area to area. Often older people who are gardeners, because it gets into the soil. For children, there's a dispersible tablet of roxithromycin, 50 milligrams. So under 40 kilograms, you can give 2.5 to 4 milligrams per kilogram, maximum of 150 milligrams twice daily. Children over 40 kilograms, 150 milligrams twice daily. Pneumonia, we have a Curb score, and that's confusion, blood urea nitrogen up, respiratory rate greater than 30, BP 90 over 60, age 65 or older. In a sick patient with a blood pressure 90 over 60, that to me would be a referral to hospital, because that says septicemia. So again, we're worried about the older people. And this is a classic chest X-ray of a lower lobe pneumonia. This would be a strep pneumoniae. So this patient would have most likely a fever, tachycardia, and lowish blood pressure, and not be feeling very well. And an older person, this may present with normal vital signs, but with confusion. So old people with confusion either have a pneumonia or a urinary tract infection. And so empirical antibiotics are a good idea there, because the pretest probability of a bacterial thing are quite high, and older people don't necessarily have abnormalities in their vital signs. And so in terms of Curb scores, 0 to 1, it's okay to treat somebody at home. The mortality is about 2%. If the score is 2, you might admit or watch closely. There's a 7% mortality. And if it's greater than 2, you'd admit, because the death rate is 14 to 28%. In terms of pertussis is an insidious urinary upper respiratory tract infection with cough. Cough may end in vomiting or apnea with an inspiratory whoop in younger children. Infants may not whoop. You can see the Auckland Pathways, and the username is connected, and the password is healthcare. In terms of prophylaxis, I'd look at the pathways. You want to protect children under the age of 1 year or under the age of 5 years who are unimmunized or partially immunized. The dosing is complicated. No antibiotics are needed for workers at schools or early child centres without infants. Contacts only if shared vehicle space, if family members are deemed non-infectious, if coughing's been going for more than 3 weeks, if all the family have completed 5 days of antibiotics. In terms of pregnancy, you want to give patients the pertussis vaccine for all pregnant women 28 to 38 weeks, regardless of previous pertussis immunization. This protects the neonate. If you want to look at a very sick child in Starship, have a look at this YouTube video. It's pretty horrifying. It'll make you rush to get a pertussis vaccine. Influenza, we only bother testing for influenza in high-risk patients where a diagnosis may alter the management and lead to or avoid hospital admission. You might want to do it in immunocompromised patients, pregnant, those with significant respiratory illnesses or other comorbidities. The use of oseltamivir, Tamiflu, is controversial. The reductions in symptoms is modest, reduces symptoms by 12 to 24 hours if started within 48 hours. And there's a risk of nausea and vomiting. You want to confirm that the patient has at least one respiratory symptom, because a patient who looks like they've got influenza but they've got no cough, runny nose, or chest symptoms or signs may have septicemia. That's the scary alternate diagnosis. These people look very sick. If they're not hospitalized, they can have paracetamol, perhaps ibuprofen. If they've got nasal symptoms, rhinitis, decongestants, you can give them a decongestant. A dose of pseudoephedrine will make them look markedly better. Reassess in a couple of hours. Often these people are too sick to come in and they actually stay at home. They say, I had such a bad flu, I couldn't get out of bed. They've probably had influenza. A true influenza will really knock you. Laryngitis, these are patients with a hoarse voice. Antibiotics may make no difference to these people. And you have to reduce their speaking demand and find out how much speaking they're doing. So if they're a teacher, they may have to take a couple of days off work, otherwise their voice won't come back. So it's a problem of the vocal cords, essentially. Croup, antibiotics, no help. Dexamethasone is the treatment of choice, but not easily available here. Prednisone, 1 milligram per kilogram for 3 days. There's a pathway on that one. Urinary tract infection, you only need to do a midstream urine if there have been a lot of previous infections, as the patient may have resistant organisms. However, nitrofurantoin is now first line, and that has virtually no resistance. The bacteria have no resistance to it. The dose is usually 50 milligrams 3 times a day to 4 times a day for 5 days. I find on the 4 times a day, the patients often get nausea, so I drop the dose to 3 times a day. You can't give it to people who've got EGFR less than 50. Trimethoprim is now a second line choice. So in summary, respiratory infections are common presentation in primary care. Many consultations should not result in an antibiotic prescription, so keep the antibiotic gun in your holster. Antibiotics are discretionary rather than mandatory, and you need to check out patient expectations. And that's the end of the talk.